Naqvi,
That's correct. Yep,
Naqvi,
yep.
okay. He's a board-certified cardiologist. He works out of Advocate Christ Medical Center, South Suburban or Trinity?
I do go there sometimes, mainly
Okay.
based out of Christ. So.
Okay,
Yeah.
awesome. His office is right here on Cicero Avenue. He went to Midwestern College of Osteopathic Medicine, and he also did his residency at Providence. Was that in Rhode Island?
Michigan. No,
Or
no.
Michigan?
Ascension Providence Hospital is a Michigan State hospital. Yeah.
Okay.
So.
Awesome.
Yeah.
Well, we're very happy to have him. He's an excellent speaker. You will
thank you.
learn a lot. And thank you so much for coming in.
Appreciate you battling the
wonderful
elements.
weather.
Yeah.
Yes, it's not cold like it used to be, but I've heard it's a little slippery.
It is slick. Yeah.
Be careful on your way home, walking and driving.
For sure. It's deceptive actually, because it doesn't look like it's that.
That's when it's dangerous.
That icy. Exactly. It's the black ice. Yeah.
So caution.
Yeah.
Right. All right.
Thank you very much.
So
Really appreciate it. Thank you for having me, everybody. So we'll get into a little bit in terms of heart health. It's really mainly we're looking at actually atherosclerotic cardiovascular disease, which we call ASCVD for short, because it's a lot easier to say than atherosclerotic cardiovascular disease. It basically also goes by other names: heart disease, coronary artery disease, you may have heard. But ASCVD is a little bit more encompassing, because the truth is that it's we're talking about basically plaque formation in the arteries, not only in the heart, but in the vascular system. So that can affect our brain, it can affect our legs, and even our gut arteries. And so that's why we use that term. And so just a little bit, we'll go through background. What is it? What can affect it? How can we test for it? And then what can we do for treatment? I just very briefly talk about medicine, but I want to focus more so in terms of lifestyle. I think that's going to be more, important for this audience: diet and exercise and sleep and those sort of things. And I have like a slide, I think, on smoking as well, which of course is bad. All right, so just a little bit of background. Cardiovascular mortality, when we look throughout the last century, you can see, I'll use my mouse so the people online, this is sharing online, right?
Yes.
Okay, so the people online can also see it, but we have that in, the wake of the 1920s and coming out of World War I, big increase in terms of our cardiovascular mortality. And that largely came because we had an aging population, we had more wealth, and people also the way the economy and everything was working. It just basically allowed for the population to grow, and then this started to affect them more. And so what you have, actually, we'll see a couple of inflection points. So here you see one, and then you see a big turn here. And really what that was around this time we had that bypass surgery was first created. And then very soon after that, within about 4 years of that, we had the Surgeon General start warning about smoking. And that's where you really start to see this turn. And then, by this point now, it's really started to catch on in the society, and we start to see a downtrend in terms of the cardiovascular mortality a bit. And then we see it further go down when we had statins, the medication class, come out. And you'll see there's a little bit of, ups and downs a little bit. And particularly here, we start to see that it's maybe starting to rise again as we have more obesity, more diabetes and that sort of thing, kind of more prevalent in the society. Again, ASCVD is the leading cause of death worldwide, even now. Cancer, some people might argue that sometimes people will say, for example, cancer might maybe be a little bit more prevalent, but a lot of times the death certificate, the default, they'll put cardiac arrest, and so it kind of gets lumped in. But regardless, whether it's number 1 or number 2, it's still a massive problem, right? There's a lot of different risk factors at play here. Definitely a lot of this talk is focused on cholesterol, and the more and more that we've looked at it, really high LDL cholesterol, or the bad cholesterol as it's sometimes called, is really kind of our major problem. We have low HDL listed as the good cholesterol. When that's low, that might have a role, and it does a bit, but nowhere near to the same degree. And in fact, the more that we've kind of looked into this, the more we realize it's probably not quite as important, the HDL, as what we had thought in the past. In fact, there's certain drugs that we've had to have raised the HDL without turning out to make an impact in terms of our cardiovascular mortality and that sort of thing. High triglycerides, another area where probably some signal that it does impact, not to the same degree as the LDL. And then you've got, these other areas that are kind of being more explored in terms of the density of the particles, the size of the particles. Smaller and more dense is bad. And then we have also what's called the LP little a, or lipoprotein little a. This is a different type of molecule as well that I actually advocate that really most people should at least have a screening for once. And we see that certain families tend to have that high, and those people tend to be higher rates, have higher rates of premature heart disease, and also sometimes what's called aortic stenosis, a valve issue. So on top of that, of course, there's a lot of other health issues that can play a role here. So people who have other health issues like diabetes, high blood pressure, smokers, these all can result in formation of plaque. Another really important thing to keep in mind is that this is not a binary disease. This is not you have plaque or you don't. It's a continuum. And we'll go through in a minute here where we start from just a small little fatty streak and to where that can eventually develop into a more severe plaque that can now encroach on the vessel and then start to limit the flow and that sort of thing. Also to keep in mind that when we have it form in one spot, you have plaque form in one spot, it's not like it typically preferentially is blocking one artery. Usually if you're going to have it in one place, it's going to end up in other places. So if you find that there's plaque in the arteries of, for example, the legs, you might have artery blockage in the heart or in the brain. And so that's why that becomes really important. And then lastly, when we talk about plaque formation, this is specifically a problem of the vessel wall, right? It's not that there's a plaque that's just kind of like attached somewhere, but it's growing actually within the vessel wall. And so this is kind of a nice illustration that kind of goes through all that. And so on the left side here, we have our normal blood vessels. When we're born, we have got these nice smooth arteries. And there's different layers that we can talk about there, but really, mainly we've got, a nice smooth wall. Over time, between all of these risk factors that we've talked about, smoking and cholesterol and, our genes and our diabetes and things, we start to develop first a little fatty streak. So a little tiny, like you could think like a brush stroke that comes across of fat that has now deposited there in the wall. Eventually that starts to get more pronounced and we get not just a little streak, but now a deposit of lipid, which basically is like cholesterol and fat and that sort of thing. And then eventually we start to get some inflammation that gets in there. So we get these red and white blood cells, and that inflammation eventually can, first of all, be a risk factor in itself for developing a heart attack. So we'll come back to that later. But on top of that, you also have that, the body's mechanisms are kind of trying to calm it down and prevent that plaque from growing. And if that continues, then eventually the plaque starts to grow. And we also, as the plaque's been there a little bit longer, start to get these little deposits of calcium or calcification. That is an important point that we're going to come back to later in the talk too. So keep that in mind, that we have this calcification. And then that calcification, as it gets worse, we start to get actually kind of this calcified shell. And this is something that we can detect. And then that also kind of forms scar. As it continues to grow, we get more and more inflammation. We now here start to have, I don't know if you can appreciate here, maybe I can zoom. Oh, there we go. Okay, so can you appreciate here? We have this area here where it's a little bit thicker, and then here it's a little bit thinned out. Can you see that? So this is where we say the plaque is more vulnerable to pop or burst. And that is actually where a heart attack comes from, or if it's in the brain, it's a stroke. That we have that, this plaque has now grown like a balloon, it just pops, and then now this has burst, and everything now to the right here is all the heart attack mechanism. And so basically now this is burst, the body tries to seal that, to plug that, and it does so using platelets, which are like, these fragments that we have in our body that are in our blood to kind of form a patch, and then we get a clot that forms on top. So that's basically what's depicted over here, is it's trying to seal it, but then it blocks off the blood flow, and now anything downstream of that is not getting enough blood flow, then that muscle would die off, and that's basically what we have as a heart attack. And here now, this is the aftermath, that it's got the patchwork, and now it's more narrowed and all of that. That's if we're lucky enough to have the restoration of flow, which we might not always have. Any questions on that so far? Okay. Let me see if I can go back there we go. Okay. All right. So, as you kind of heard me allude to, there's a number of different factors that are involved here with this, right? We have, for example, our cholesterol, right? That's really what's forming the basis of this initially, as well as actually one of the main things driving the growth of that plaque. You've got inflammation. You've got things like metabolism that also play a role in the background with our hormones that are kind of actually playing a role in the regulation of that plaque. You've got our platelets and our coagulation, and that is particularly in that last step. And so while there's all these different things at play, the flip side as a scientist is that we also have different targets where we can actually impact this and improve our therapy. A lot of these are kind of more in the the exploration phase, or earlier on. By far and away where we've had the most impact is with our cholesterol, and then of course our diet and things that maybe play on this in other ways rather than our specifically medications. So in terms of what's affecting our cholesterol, the next 3 slides look very, very dense, but I'm basically going to summarize it very quickly. Diet, medicines, certain metabolic diseases, and other diseases can affect our cholesterol, our bad cholesterol going up, as well as our good cholesterol going down, and our triglycerides. And so, for example, of course, highly saturated fats and processed foods, those things can cause higher LDL. Things like certain medicines, like our steroids and our diuretics, certain things like that can actually increase our LDL as well. Things like going through menopause, diabetes, hypothyroidism, this can also losing protein through what's called nephrotic syndrome through the kidneys. HDL similarly, again, high processed diet, diabetes is on here again. And then triglycerides, alcohol is a very big one there, along with our simple sugars, things, our sugary foods, drinks and things like that. So yeah, that's really the main takeaway with these. I also want to focus on that there are certain conditions that make us higher risk for atherosclerotic disease to form. So typically as we age, we're more likely to have these sort of things happen. It's a mix of a lot of different things. We mentioned before, for example, women, menopause is there, but in general, on top of that, we have certain changes in our vessel wall that makes them less stretchy. And so those can play a role here. Of course, wear and tear and everything like that with our age also. Certain genetic conditions, for example, we have what's called familial hypercholesterolemia. Those people have very, very high cholesterols, even at young ages. Of course, if somebody's had heart disease, you're more likely to have a heart attack, right? Diabetes, high blood pressure, kidney disease, smoking is a big, big one. And congestive heart failure. So how do we assess someone's risk? It's we have this calculator. This is just a screenshot showing that. And actually, anybody can really access this if you just Google ASCVD Risk Plus calculator. This was put out. It's a joint effort amongst a number of societies, including, the main headliners would be the American College of Cardiology and American Heart Association. And basically what they do is in this, you plug in someone's age, you plug in their gender, you plug in their ethnicity, and then their numbers, blood pressures, cholesterol, were they ever a smoker? Are they on any treatment for example, blood pressure, anything like that? And then it's able to spit out for us at the top this 10-year risk. There is also sometimes this lifetime risk. And then here they have here the optimal risk. So this is somebody they're really tried to make it look super rosy. Usually you don't have that much of a differential here, but they're saying this person is someone who, you know, is quite a high risk, you know, more than a third chance they're going to, in the next 10 years, have a heart attack or a stroke. Whereas if they were to get their blood pressure under control, get on a statin, you know, all those things, you'll get it down to 5.8%. So again, that's usually more of a differential than we'll see usually in practice, but certainly we can see big reductions if we improve our lifestyle. This is actually a screenshot specifically from our guidelines, and it's a busy slide, but I just want to kind of highlight a couple things. Number one, this is kind of how we as practitioners think about this, how we approach, you know, we look at someone's age, and then based on the age, then we, you know, we'll type in these numbers into our calculator and then use that to make our decisions. Certain times we bypass that altogether. Someone's got familial hypercholesterolemia, their LDL cholesterol is above 190. Don't even think about them. We put them straight on a cholesterol medicine, on a statin. If somebody has, again, diabetes and they are above the age of 40, they should be on a statin medicine as well. And in terms of the how high of a dose, you know, that's where that factors in as well, in terms of some of the other risk factors. Outside of that, really anybody else, we look at their risk down here, and we have to figure out, is it someone who's low risk based on their calculator? Then we only talk about lifestyle. If someone's at a higher risk, we should definitely start a medicine. And then if it's somewhere in between, then we might consider a medicine. We have a conversation with people. And then there's certain other things that we can do that will help bring out someone's risk a little bit better. We have other tools to prognosticate better. And the best one, in my opinion, of those is what's called the coronary calcium score. So I'll get to that in a second. But I want to focus also here that this is not a perfect tool, right? This calculator that we have is something that we can use to give us an idea of somebody's risk. It's not like this is your exact risk, right? This is making a lot of assumptions based on other people that would fit your similar age and gender and things like that. And it doesn't include certain things. And that's really where this left side comes from. For example, if somebody has a strong family history of premature heart disease, this would not fall into the calculation. So, you know, for example, we see sometimes people that are in their 30s that come in with a heart attack. And if we follow that, they might have come out with all these factors that would put them at a low risk. But in reality, they were harboring this. So there are certainly exceptions we have to take into account.
Sorry, what do you mean they were harboring it? What did you notice?
So what I'm saying is this, by this point, they've already shown themselves, they've come in with the heart attack. But my point is that the risk calculator is not always perfect. And that's why it's important for us as practitioners to take in a thorough history, for example, right? So if I find out that somebody has had a very extensive history of premature heart disease, I'm going to be a lot more aggressive in terms of my prevention strategies, working on the diet, the exercise, those sort of things. I might be a little bit more inclined to get some other testing that I would normally not consider in somebody else like that. Does that make sense? Okay. Other things like, you know, chronic kidney disease, metabolic syndrome, which I have a slide on that. Certain pregnancy-related conditions. If someone has had a history of preeclampsia, that's another risk factor here. South Asians tend to have higher rates, unfortunately. You know, a couple other things. We mentioned the lipoprotein little a, for example. So anyway, so I mentioned this coronary calcium score. This is a really, really nice tool. What this is basically a non-contrast CT scan that can take a look at the chest and look at the arteries of the heart to look specifically for calcified plaque. Okay. And so we have a very, very well delineated data set that we're building off of from, you know, tens and tens of thousands of people that have had these. And we can say, based on this calcium score, much better, what is somebody's rate of having heart issues, right? Heart attacks, strokes, et cetera. And, you know, there's a really huge study called the MESA study that really did a really nice job. And in fact, this can really season our risk calculation better. If somebody has a calcium score of 0, it's exceptionally unlikely that that person over the next 10 years would end up having any problems, right? In terms of heart attacks or strokes. It doesn't 100% rule out that there could be some soft plaque, but exceptionally unlikely, right? Exceptionally unlikely. Whereas somebody has a very high calcium score, they're much higher rates in terms of having those issues, right? And so this is kind of a picture of what it looks like. You know, you basically would lie down here. They have it, you hooked up to some EKG leads, and then it goes through, and the CT scan is, you know, a quick second that it takes a snapshot. And then this is an example where we see no calcified plaque. Here we see this bright white. This is the calcified plaque. And, you know, just again, to link it back to this previous slide, remember we mentioned here that there's this calcification that comes a little bit later on. So this is what we're detecting with this calcium score. And that's why we see such a great relationship between someone's score and someone's outcomes. I think that's mainly it here. And so this is where we divide it. You know, we have 0, a calcium score of 0 is, you know, that we have no evidence of plaque. 1 to 10 is minimal. 11 to 100 is mild. 1 to 400 is moderate, and then above 400 is extensive. I've seen as high, the highest one I've seen is, you know, above 10,000. Yeah, that's not great. What does
that mean, 10,000?
So basically the way that this is calculated is that we have, you know, there's some tools that we use with our software to be able to look at both the density and the area of the plaque. And there's, you know, there's some basically calculation that happens in the background, and that'll give us what the score is. Okay. And again, above 400 is considered to be extensive. So this is a really, really nice study we had where it looked back at people, you know, tens of thousands of people, and based on their calcium score, we divide them into quartiles from 0 in this top corner to 100, 1 to 100, and then above 100 to less than 400, and then above 400. So basically what we're having here is, and maybe I can zoom in again. Sorry. Okay, so basically what we have is that the blue line is supposed to represent if someone is not on any statin medicine, and the red line is representing if they have been taking a statin. Well, you can see that when this calcium score is 0, from the whole time period of this study, which was 12 years, there was really 0 difference, right? Did not make any difference. Whereas when we get to above 1 and less than 100, we see that it's starting to differentiate here at the 12-year mark. This actually missed statistical significance, but it does kind of trend in that general way. There are some times here where I will still keep people on medicines, and specifically the other number that's reported on your calcium score is also the percentile, meaning when we compare your score with other age and gender matched people. So say, you know, someone is 45-year-old male and they have their calcium score, and then we will compare it to another 45-year-old, you know, say Caucasian, for example, Caucasian male. We'll compare the two, and then we'll see if someone has a lot more plaque than their cohorts, then they'd have a higher percentile. So say they're like a 90th percentile, that means 90% of people have less plaque than them, okay? And so if that's the case, now I'm gonna be a little bit more concerned about that person, because now I'm also thinking, well, this is at 12 years, what happens the next 10 years after that, right? So that's that. When we come to our 101 to 400, we see a huge difference. And right away, you can see that the lines separate over here, and that this is highly statistically significant as well. And so, in fact, when we get to above 400, the curves are closer to each other. It's still significant, but basically you see that the red line is steeper, right? And basically the idea is at this point, the plaque has already deposited. We're catching them later. So there's less that we can do to prevent. It still is preventing things, but not as much as if we can catch it earlier. And so that's why this test is so beneficial to us, that we really, really get a lot in terms of our prognostication with that. Okay. And then just in terms of numbers, we're talking about roughly say 20% here to about 5% with the medicine. So big improvements with that. Okay. All right. So moving on, I had talked before about metabolic syndrome. Metabolic syndrome, just to give you a little background, basically we have to have 3 at least of the following. You have a waist circumference above 40 in men or 35 in women. High triglycerides, the general fats in the blood, a low HDL, which is the good cholesterol, less than 40 or less than 50 in 40 in men, 50 in women, high blood pressure above 130/85, and then fasting sugar. So if you have 3 of any of those, then that would be a sign of what's called metabolic syndrome. Oops. And that is one of the risk enhancing factors we mentioned before, along with, for example, South Asians or high Lp(a) and et cetera, family history. All right. So moving on to treatment. Okay. So we'll talk just a little bit about our medications, and then we'll focus, the rest of the talk on the diet and exercise, et cetera. So medications, by far and away, the mainstay of our treatment for cholesterol here, and also for plaque stabilization and prevention of plaque growth, is our statins. Statins, as you saw in that first slide I had up, where it started to kind of take a dip in terms of the curve. It's been around since the 80s. Of course, our meds now are better than they were when they first came out. Now we have stronger statins that are less likely to cause side effects, although that is definitely sometimes still an issue for some people. But we know very well established that not only does it help reduce our cholesterol, but it does certainly help reduce our rates of heart attacks and strokes as well. It also, forms that stabilizing layer to prevent that, that thin, vulnerable area where it can burst, we talked about before. So this helps kind of form that stabilizing layer as well. Based on the dose of the statin, we can see basically 20% up to 50% reduction in our LDL cholesterol. Bile acid sequestrants, we really don't use too much now, between side effect profile, and then also we really want to focus not only in terms of just lowering our numbers, but actually downstream effects of that, which is how can we at the end of the day prevent a heart attack or a stroke? That's what we really care about. And so statins, again, that's where that comes to be our main thing. Ezetimibe is another one that we do use, but it's relatively modest. 15% or so reduction in our LDL. And so usually we can see a little bit of improvement on top, but that on its own is usually not enough for most people to get our cholesterol down to target. We have some newer medications here, the PCSK9 inhibitors, our bempedoic acid and inclisiran. These are all within the last decade, and the last couple of them really in the last 3 years that we have. And so all of those are brand names. In the case of PCSK9 inhibitors and inclisiran, those are injected. One is subcutaneous, kind of like how insulin is, but it's every 2 weeks or every 4 weeks. And then inclisiran is actually given in the clinic every 6 months. And so those we see, at least in the case of the PCSK9 inhibitors, we see really big improvements, 50–60% improvements in our cholesterol, LDL cholesterol. And with that, major improvements in terms of our longevity, heart attack, stroke risk, and that sort of thing. And, maybe even some plaque regression a little bit. Bempedoic acid, a little bit more modest. When we combine it with ezetimibe, there is a mixed pill that has both of them, which you give about 35% reduction. And there is some, again, improvement in our outcomes with that. So in terms of, just very quickly, in terms of statins, this is just a list based on our dosage and the name of the medicine that will give us, how intense is it, basically what percentage of lowering. It's just really more included for completeness sake. It's not as important for you guys. All right. Yes. I'm sorry? Inclisiran? Inclisiran is the one I mentioned is given every 6 months by injection in the clinic. This goes by the brand name Leqvio. This one is, I think, the newest one on the list, actually. So we get about 50% reduction there in terms of our LDL cholesterol, which is really nice. We don't yet have outcomes on it. It's going to be positive because really anything else that has shown a major reduction in LDL has been positive. So I'm sure it will be, but we don't have that yet. And so the biggest issue with this is just approval from insurance companies because it's extremely expensive. So I've myself not had actually, to be honest, a ton of success with it, but anyway, it definitely works though. The patient, a couple of patients I have on it have seen, big improvements in their numbers. So, yeah.
So the way the list's set up, there would be your continuum. Let's say you first try to treat the statin, that doesn't work. Go to the bile acid sequester.
Usually we don't use the bile acid. So for the most part, it's statins are kind of our baseline. And we usually go what's called maximally tolerated statin. So somebody, most people can handle them okay. So we'll have them on, like, for example, here on this, we have our 40 milligrams or 80 milligrams of atorvastatin, 20 or 40 of rosuvastatin. Those are our only high intensity ones. Some people might have side effects. The most common side effects typically are muscle related. I'll just quickly mention that if we look at the people who think they have muscle-related symptoms because of the medicine, turns out actually about 10% truly is from the medicine. There's ways to tease that out and everything, but there really is, because so many people are on these medicines, there really is a large group of people that have muscle issues because of those medicines. And then finding what that dose is going to be different for each person. I have some patients, for example, that are on 5 milligrams of rosuvastatin, which is a relatively low dose. They can take it 3 days a week. If they take it 4 days a week, they start to get symptoms, and 3 days they're fine. So for example, that's kind of teasing that out. There's other people that can handle the highest dose. Actually, I have one patient who was on 80 milligrams of atorvastatin, which is our top dose, and he mistakenly was taking it twice a day. And so I was like, wait, slow down. You're taking too much. He ended up doing okay. He was okay, but we cut it back. But the point is he had no symptoms, right? So our bodies are all a little bit different, and maybe in another decade or so we'll have precision medicine. I can tell you, oh, you're going to have muscle aches when you take 10 milligrams or whatever. But anyway, so we'll look at that finally, the maximally tolerated dose, and then the next thing is then reassessing our cholesterol and how far are we from the mark, right? One thing I didn't include in the slide is where is our target in terms of our LDL. So somebody has now gotten to the point where they have actually had a heart attack, or they've got a very high calcium burden on the calcium score, or someone's had a stroke, something like that. These are high risk people. So in those cases, our American guidelines will say ideally less than 70 LDL, or sorry, less than 70 or ideally less than 55. I usually, for the most part, shoot for that lower number. The Europeans and the Canadians have adopted that 55 number. So usually I shoot for that. And then also the other, benefit to that is that usually LDL of 60 is around that kind of cusp where we go from adding plaque to starting to reverse it a little bit. So that's another thing, is plaque reversal. There's other factors, of course, at play. Like if somebody's got an LDL of 40, but they're smoking, you'll still be doing damage. But anyway, so basically how far are we from that mark? That's what will determine what other medicines we might use. For example, if somebody has an LDL cholesterol of 120, I'm trying to get them to 50, I'm not going to be able to do that with ezetimibe, right? I might probably get them with a PCSK9 inhibitor though, okay? So that's kind of where that comes in. Make sense? Okay. All right, any questions also about the, oops, I did not mean to do that, sorry. About the meds before we move on?
So person without any type of heart event, what's the target LDL?
LDL, usually we talk about 100. Yeah, usually less than 100 is a good kind of thing. And, depending on where we are with this is where we'll decide, do we need to be more concerned? Our risk percentage, that's another thing. It's where we also, and if you notice here, actually on this slide, they talk about moderate intensity statin rather than it being a high intensity. High intensity is going to be, for example, somebody's got diabetes and they have a higher risk, then we'll do that. Or somebody's already had plaque or something like that. Okay. All right. Exercise. So exercise is extremely important. We had a really nice talk. We also listen to talks too. And so within our advocate system, there was one for our cardiology section a couple weeks ago that was entitled Exercise the Fountain of Youth. And so it really is super important. Typically, we talk about trying to get in 150 minutes a week of moderate intensity or 75 minutes of vigorous activity. So what does that mean? The way that you can think about it, I do have a slide that kind of goes into what that is a little more, but just a very basic kind of thing. Moderate intensity, you're walking, you're having a conversation, maybe briskly, but you're having a conversation, but you can still breathe, right? Vigorous is you're breathless. Another way to look at it, a lot of people use like smartwatches and heart rate monitors and things like that, which are a lot of times color coded. And so in terms of your heart rate range, so if you are in the green or yellow, that's going to be moderate. If you're in the orange or red, that's vigorous. Okay. This is kind of our minimal, at least 150 minutes a week of moderate or 75 minutes of vigorous. And basically, they say if somebody's not able to do that much, just do something. Actually, I think I have a slide in here. Yeah, this is from our guidelines. So class 1 indication that we should be talking to you about physically active lifestyles when you come to see us, but then also that we should be encouraging these things. And then the 2A one in the yellow is that if you can't do it, at least do something, essentially. And then try to cut down in terms of the sedentary, meaning don't be sitting around all day. There's some benefit for getting up and moving a little bit, intermittently. On top of, in terms of this exercise, another thing is it's not just doing aerobic exercise, right? It's not just, for example, walking or biking or things like that, but actually resistance work is super important too. So some weightlifting or, and it could be light weights, that's fine, but or push-ups or things like that. Something to build your muscles or tone the muscles. You don't need to be Arnold Schwarzenegger in his youth there, but just some kind of resistance work is really helpful, and that can reduce all-cause mortality as well. It also helps. The other thing is yoga. Yoga, I actually am a big advocate for. I mention that to all my patients. It can lower blood pressure. It helps with cholesterol. It can lower your blood glucose levels. And then on top of that, there's all these other benefits with balance, with flexibility, especially as we age, that becomes super, super important, right? On top of our cardiovascular death, falling, breaking your hip can be a major, major issue. And that's less likely to happen if you've been working on your balance and your flexibility. On top of that, there's also like the breathing and the calmness of mind and stuff like that goes with it. So they basically say, try to get in, if you can burn 2,000 calories a week. So, that's basically like 1 day of your normal diet that you would have burned off. And that if you can achieve that much, that's when you'll start to see really the major benefits in terms of the cholesterol and that sort of thing. And if we kind of just zoom out and just look at our society, I actually am surprised that it's only a half, but they say about half of the US adults are not meeting our minimal physical activity recommendations. The other thing that I think is really important, aerobic activities is usually pretty safe, right? A lot of times people worry, oh, will this be safe for my heart and can I do this? But in general, we found that for the most part, as long as you listen to your body, like if someone's walking, they start to have chest pain, don't keep walking, right? But the point is that if you're feeling fine, you should be able to go for it. You shouldn't feel like, oh, I'm not able to do this. It's not safe for me. Usually we say if you're not doing anything, just start with kind of a slow walk. And having a regular kind of schedule is really important. So, even say 3 days a week, you're walking 10 minutes. That's a good start, right? And then build it up from there. That from there, you make it 15 and then 20 and 30, and then increasing the pace as well. Definitely at least 2,500 steps a day. Does anybody know, I'm sure everyone's heard of this 10,000 steps a day. Do you know where that came from? I actually learned this in that talk I was talking about before. Actually, it was just some businessman that created a company. He just created the idea of 10,000 steps. And so it kind of came arbitrarily, but 2,500 steps a day is kind of our minimum that we need to really see the benefits, at least that much. Obviously, you'll continue to have more benefits as you're more active. And yeah, there's no lower limit to where exercise benefits begin. And I have a really nice slide on that in a second. But really quickly, we talked also before about in terms of our intensity of our exercise. So moderate, we have in medicine this idea of metabolic equivalence or METs. And so basically, you know, when we're just sitting, we're achieving 1 MET. So we're basically not doing really anything. If you're doing some slow walking or, you know, light housework sort of thing, basically that's 1.5 to up to 3 METs. If you are doing a brisk walk or, you know, some active yoga, some biking at a kind of a decent pace, a lower pace, then that's 3 up to 6 METs. This is where we talk about moderate intensity, right? Another way that we kind of sometimes will look at this is, you know, if people can achieve at least 4 METs, we know that their risk of undergoing a surgery, for example, is quite low. So 4 METs, we also look at, can you mow your lawn without having to stop? Can you do 2 flights of stairs? Can you do 4 city blocks without having to stop and take a break? So that's, you know, I would say we should at least be able to do that much, right? But ideally, if we can do vigorous, which is things like jogging, running, biking at above 10 miles an hour, swimming laps, or singles tennis, that would be above 6 METs. You know, if you wanted to also beyond that to quantify this for yourself and get an objective measurement, our regular stress tests when someone's on a treadmill will always give you this number printed out as well. But anyway, you know, being able to exercise at a vigorous pace cuts down the amount of exercise you have to do by half. So that's another bonus there. This is a really nice study that was from 2016 that basically shows our level of activity in these METs from on the left side 0 up to 10. And we see, I mentioned 4 as our magic number in terms of from surgery, that if you can do at least 4 METs, so that's again 4 city blocks, 2 flights of stairs, that they'll probably be fine in the surgery. This is where this, you know, this is not where that comes from, but this is something that reinforces that idea. And so when we see somebody's risk of a stroke in the light, in the solid blue, this is the heart disease. This is diabetes in the green, and then this is breast and colon cancer. You can see that they're all pretty high, and it really starts to drop off considerably up until this point. In a couple of these, there's a continued downward trajectory, just mildly, but really by far the bulk of the benefit you get is you have to at least be doing 4 METs. Okay, does that make sense? So if anybody's there that can't do 4 city blocks, that's got to be a minimal target. Okay. 2 flights of stairs or 4 city blocks. Okay. All right, moving on to diet. So in terms of diet, you know, the first point there that I have there is that, you know, we don't have a lot in terms of randomized controlled trial data that's like, you know, scientists speak for. Basically the quality of the data that we have is a little bit harder to study compared with some other things. But the point is that and the reason I only mention that is that sometimes there's certain things where you'll read one article will come out and say, oh, eggs are bad for you, you shouldn't have eggs. And then the next like week, you'll see another article say like, oh, eggs are good for you, you can eat eggs and it's not a problem. And this is one of the reasons, is because it's a little bit tough thing to study, especially when we're talking about what's called primary prevention, which means someone who's never had a heart attack, never had a stroke, and we're trying to see what's the rate that this general population will have that, because the numbers are relatively low, and then it's a hard thing to study, right? How do you prove that somebody's eaten only this all the time? And that's where it becomes difficult. But in general, there's very, very clear trends, right? More plants, essentially. So more vegetables, more fruits, more nuts, more seeds, more, you know, lentils and things like that. And then as well as things like whole grains as opposed to processed things. More fish, for example. I always talk about, you know, leaner meats, more chicken and fish over red meats. Grilling and baking food, especially baking or boiling as opposed to frying, right? Trying to have less saturated fat. Essential fatty acids, you know, omega-3s, omega-6s, those really come from things like seeds, from things like avocados, from things like again, chia seeds, flax seeds are on there. And then of course, you know, some of your fishes, salmon, for example. Trying to watch out. Yeah.
I had a question on the, it's canola, soybean, sunflower oils. I think they're loaded with omega-6,
Mm-hmm.
way little omega-3.
Mm-hmm.
And I think there's research coming out nowadays that is pinpointing that they're actually not that healthy for us as we were led to believe.
I think that, first of all, when
They're industrial seed oils, I think they could be problematic, so.
that is a fair point. I think that first of all, there's also other things that go into that too, in terms of, for example, like melting point and carcinogens and things like that can be there too, which maybe those are not necessarily the best when we're talking about cooking. I think that, you know, particularly though, if you're talking about the source, and you know, I could be data I'm not aware of, it's fair to say, but if you're talking about just having sunflower seeds, for example, on their own, that's actually, you know, super beneficial. But yeah, in general, I mean, I usually tend to use more olive oil and you know, that more ghee tends to be really high in saturated fat. I won't not ever use that, but you know, it tends to be, especially from a South Asian background, it's employed in the cooking a lot. But for the most part, by far and away, I tend to use avocado. I tend to use olive oil the most.
Olive oil.
Yeah, that's what. Yeah. Anyway, other than that, certainly, you know, trans fats is a big thing to avoid, and that, of course, we've seen a ton of transparency in the last, you know, decade and a half or so, to where they, you know, they're basically trying to force it to be outlawed for the most part. You know, if we're looking at specific diet plans, the Mediterranean diet has the most data behind it, and then the DASH diet is another one. DASH diet, it stands for Dietary Approaches to Stop Hypertension. So it's created for people with high blood pressure, and basically, you know, that's the best use case for it, I think. I'd say for all comers, if you're trying to adopt more of a general plan, would be more of a Mediterranean diet. But DASH diet certainly we see around 11 points improvement in blood pressure for that. So that's really beneficial. In terms of, you know, the other thing is, I kind of alluded to this before, you know, more of a plant-based diet is definitely beneficial. And, you know, I'm not a vegetarian or a vegan myself, but I kind of look at that and at least try to adopt more plant-based foods. And so actually what we do is we're subscribed in our house to a meal kit delivery that is a plant-based one. And that's kind of my way of, you know, taking the guesswork out of like, what are we making for dinner, and kind of introducing more of that as well. But, you know, one of the things that kind of where this comes from, there's this trial that's called the Adventist 2 Health Cohort. And what this was an observational study, but basically it looked at people that specifically replaced the protein section. There was a subgroup that replaced it all with more animal protein, more meat, basically, and another that replaced it purely with plants. And so most people had a mix, right? That's what most of us do. But some had done purely just animals. They had a 61% increase in heart disease. And then the ones who went to purely the plant-based went to 40% reduction in mortality. So big, you know, changes there. Again, I don't think there's by any means anything wrong necessarily with having some meat, but it's about how much we're having, and then also how we're preparing it. Processed food is definitely a huge problem. And that's actually, you know, I have here that has to be healthy plant-based options. You can get an Impossible Whopper with fries, and that's technically, it could be a vegan meal, but that doesn't really count, right? That's extremely processed. And, you know, this was an article that has 18 million times more estrogen than a regular Whopper. So, you know, you have to be a little careful with some of that stuff.
Can you tell us why that's important? 18 million times more estrogen.
Oh, I mean, you know,
why that would be a bad idea for people.
Yeah, I mean, you know, I think that in general, anything that's that much concentration is probably not a good thing. I would say that in general, actually, estrogen usually is protective for heart health, and that's one of the reasons why menopause we see it go down. We see the heart rate heart disease rates going up. But that being said, this is not the way to do it. This is definitely not the way to do that. It was just kind of a funny headline. That was why I included it, not because that in itself is bad. But the point is that, you know, it was very processed, and, you know, we want to have from, you know, natural sources our diets. Fiber is another point, which is super, super important. Every 5 to 10 grams that we eat of fiber can reduce our LDL by 11 points. So that's a big point there. And we also can see some blood pressure reduction with that too. Yeah.
What do you mean by viscous fiber?
Viscous or soluble. So those are different terms. So it can be soluble or insoluble fiber. So basically, it's basically like the type of, and if you look at a food label, it'll always be listed out and break those up. But one of the ways to think about it is that it's usually like the more spongy sort of food. So for example, so something like that, you know, as opposed to like kale, right? Kale doesn't get really broken up as much, whereas this can, chia seeds, for example, or oatmeal, those can kind of trap that a little bit more and bring the cholesterol down so you don't absorb it as well. That's the idea. So yeah, we talked about the Mediterranean diet being very, very beneficial for us. And this is a really nice trial called the PREDIMED trial that looked in that. And we saw that when people switched to that, we saw 30% reduction of our ASCVD risk, our atherosclerotic risk. And so basically we have our control diet here. And then there's different ways that they did it. Were they having more olive oil? Were they having more nuts or whatever? But the point is that in general, these all kind of clustered around here versus our control diet here. And this is kind of a rough idea. And actually, you know, the control diet doesn't look too bad. Low fat dairy and lean fish, and, you know, so, you know, comparatively, maybe a little bit less in terms of our vegetables and our nuts and things like that compared with the other one. Foods to avoid, we kind of hit that with the Impossible Whopper, but just to kind of focus on that a little bit more, our processed foods is a big one, right? And so fried foods, things like processed meats like hot dogs and, you know, bacon and things like that. Sugar sweetened beverage is a huge one, actually, and that includes not just sugar sweetened, but also artificially sweetened beverages. We see that actually if somebody was to have one beverage a day, say you have like one Coke every day, 20% higher rates of diabetes and atherosclerotic risk. Southern diet actually compared with a regular diet, 56% higher rates of heart disease and 30% higher rates of stroke. And then low carb diets, you know, that's been kind of a rage recently. And we have to be a little bit careful there, particularly, again, we talked about this before with the animal proteins. If we're having a lot more meat with that, that's going to be 18 to 30% higher all-cause death. So you just have to be careful, again, where are you getting your source of the food from? So, you know, carbs are not necessarily bad. Certainly, you have to be careful if someone's diabetic, for example. Carbs definitely, particularly the more, again, sweetened and artificially sweetened things, we'll see more of the, you know, abdominal fat and things like that. But just specifically low carb is not necessarily the answer. It has to be, at the end of the day, where are you getting the sources from? So eat more plants, you know, watch the processed foods in the ship. Sleep, super important. We really, the sweet spot actually is 6 to 7 hours of good quality sleep per night. We actually have a U-shaped curve where if we have much more than 6 to 7 hours, or certainly when we have less than that, we have higher rates of heart disease. You know, along with that, you know, quality of sleep is super important. We have kind of like this normal sleep cycle where we have different phases of sleep that we go through, and that can be affected by different things. Sleep apnea certainly can disturb that. Alcohol and certain medicines, like, you know, some of the sleep aids, like especially, you know, things like Ambien and that sort of thing, they can mess with our sleep cycle. So getting good quality sleep naturally is important. And sleep apnea, you know, a little bit more about that. It's extremely common. And basically what it is that, you know, while we're awake, we have enough sense to keep our, and alertness to keep our airways open. But then when you sleep, the airway starts to narrow, and then we get an obstruction here. This is the most common, what's called obstructive sleep apnea. And that sometimes manifests as snoring. Sometimes people might just stop breathing in their sleep, and especially if someone has what's called central sleep apnea, where it's coming from the brain. And these things tend to result in things like higher blood pressure, in things like diabetes, abnormal heart rhythms like atrial fibrillation, higher rates of stroke. It's also harder to lose weight, because really what's happening is you're not getting the deep restful sleep that you need. And so as a result, you end up having higher rates of stress hormones, cortisol, and that sort of thing. And so, you know, nowadays, actually, we can quite easily look for this with a home sleep test. Sometimes we still do sleep lab, but many times we can screen for it with this home sleep test. So this is an example of that over here. And, you know, that then the data is looked over by our sleep physician colleagues, and then they can contact and say, you know, how often is it that you're stopping breathing? How low is the oxygen getting? And then prescribe you a treatment accordingly. You know, for most people, the mainstay of treatment is what's called CPAP, which is this right here. It's basically creating very soft, gentle pressure that's keeping the airway open. And, you know, it admittedly is a little bit of a pain to get used to, but usually most people, if they give enough of a try, they can get used to it. There's a lot of different masks, and finding the right mask is part of the kind of the headache of getting this process done. But once people find the right mask, most people can deal with this. If somebody is a low or moderate, particularly the lower rates in terms of severity, there's also these dental appliances that basically pull the jaw forward, and that can many times deal with that. If someone has moderate to severe sleep apnea and they have tried everything they cannot get the CPAP to work, there is also this other device that can be implanted here. I usually tell people, look, if you can try to not have something implanted, you should always try to avoid having something implanted. So usually, you know, give the CPAP a really good try. But otherwise, you know, this is definitely better than leaving it untreated. Okay.
I have a question.
Yeah.
What causes someone to have sleep apnea, and is weight or being overweight a major risk factor?
Yeah, so certainly obesity goes hand in hand with that, and in this country in particular, it's our #1 cause. And in fact, going with that, actually, I would add to this list is for many people, some of the treatment could also be weight loss, because, you know, again, getting back to this picture here, you know, you have this extra tissue that's kind of pressing on here. It's going to be more likely for this to kind of narrow. With that, though, it's not the whole story. Sometimes, for example, there could be just the shape of your neck and your throat. So South Asians, on top of having higher rates of cholesterol, tend to have higher rates of sleep apnea too. I know we get it. Great, huh? And then over here, I also want to mention that snoring is not sleep apnea. So I kind of glossed over this, but the curve here, normal, snoring, and then the rates of sleep apnea in terms of our time to death. So obviously sleep apnea and snoring are not the same, is the point. Okay.
I have a quick question.
Yeah.
So 6 to 7 hours optimal, you know, sleep. I'm a nurse. I also work night shift. So I would imagine it has a very big impact on the cardiovascular health.
Yeah. So that's a good
What do
point.
you recommend? I mean, getting the hours of sleep is one thing, but
Yes.
I'm against this. I just won't.
Yes. Yeah.
About 2 hours a day. So.
Yeah, that's really tough. That's really, really tough. So yeah, definitely actually, you know, there's data that suggests that people who are shift workers, particularly, I think it's more so people that are switching, but even to some degree, people that are working overnight, there is a little bit higher rates in terms of heart disease. That being said, I mean, you know, of course, I'm taking call overnight as well. And so, and I've got 3 little ones at home, and the youngest guy doesn't like to sleep a lot. You know, there's obviously going to be things that will interrupt it. I don't think that it's necessarily like, you know, a death sentence that God forbid, you know, this means you're going to get heart disease. But, you know, most people don't tend to do this forever, right? Most nurses are not going to be doing this for forever. They'll do that for a few years and then they'll switch to days or something like that. But I think that, partly, definitely the amount is and the quality of sleep is the most important thing. But yeah, just something to think about. Yeah. All right. Okay. So moving on to weight loss. I know these numbers don't add up here, but just in general, they say about 2/3 of Americans are either overweight or obese. And they say overweight is about 30% and obese is about 42%. So I know those don't add to 2/3, but different studies and that sort of thing. But the idea is, majority of us are not at the weight that we should be, which is one of the reasons why I was surprised that it said only half of us are not getting enough activity. So, the other thing is that BMI, or body mass index, which is basically a ratio of our height and weight, is not the whole story, because there are certainly people, and I think this is, again, looking at South Asians again, sorry to beat a dead horse, but like for me, my body mass index is okay. I could stand to slim down a little bit here. And this is where the ASCVD risk is the highest, actually, abdominal fat. So the point is the waist circumference is actually at least as important. Yeah, and then, at least 5% of weight loss is where we start to see some improvements in terms of our blood pressure, our LDL, and that sort of thing. It can also delay diabetes or cut down your risk of diabetes. Weight loss is also super important for blood pressure. I'll just quickly say that every kilogram that we lose equates to about a point of blood pressure. So 20 pounds is about the same as a blood pressure medicine. So super important. This is from our most recent trial that just was released just a couple months ago, called the SELECT trial. And it just included this because this has been in the news a lot, is this Ozempic. And this is specifically a medicine called Wegovy, which is literally the exact same medicine, but just under a different brand name in the US. The semaglutide, which is Ozempic or Wegovy, looking at non-diabetics, we saw about a 20% reduction in terms of all-cause death and CVD risk and that sort of thing. So, that's some benefit on top, especially if you've been working at it, you've been exercising, you've been changing your diet, and you feel like you're hitting a plateau. That's another option. And then very briefly, in terms of smoking, I think everybody knows smoking is really bad for you. Most people think about the cancer risk and lung failure and things like that, but it is one of the biggest reasons to have plaque form. So, I just wanted to include that. I think in the interest of time, we'll kind of move past that, but unless someone has any specific questions on it. Yeah.
So for former smokers,
Yes.
I know, is there a time from when you quit to when
Yes.
it's like you've never smoked?
Yeah, so there are things that will be reported that way. And I don't remember exactly the time frame, don't quote me on it. But it's definitely on the range of several years. I can't remember off the top of my head though, but there is that they typically say, hey, your risk is about the same as someone who's never smoked. That being said, somebody who spends a lot of time looking at coronary calcium scores, I can tell you that is definitely a risk factor that we see that accelerate. And I guess I'll just mention it. I like to give this analogy. What smoking does to our arteries, we talked about how we have nice smooth arteries when we're born and things. And so we have our cholesterol that's kind of free floating, and normally we have that smooth barrier, but the smoking kind of makes it a little rough. And so I like to give this analogy that we've got our floor here. We'll focus on the tile here. It's nice and smooth. So if you have dust, you can easily sweep it up. Now, this is probably not the best carpet example, but thinking about your carpet at home, it's got all the, the undulations and everything. So a broom is not going to do anything there, right? It's just going to kind of get trapped in between the fibers. And that's kind of like what smoking is doing to our blood vessels. That's why we see so much higher rates of heart disease. On top of that, it also causes more inflammation. And so, that area where we saw the vulnerability, it makes it harder for that to becomes stabilized and makes it more likely that it's going to pop. Okay. All right. So yeah, basically just in summary, heart disease is still the #1 cause of death worldwide. Very important to have a good idea of where you stand, where are your numbers, your blood pressure, your cholesterol. I would throw into that. I think everyone should at least have a one-time lipoprotein little a check. And then also, of course, weight, BMI. If there's someone who is, in that intermediate risk where we think that maybe they would benefit from a statin, they don't want to be on a medicine, which I totally understand. Or if there's other risk enhancing factors like, again, premature history of premature heart disease or high Lp(a), then calcium score is a good kind of tool to sort of season the risk prediction. Diet rich in fruits and vegetables is super, super important. Mediterranean diet, kind of encompasses that. Exercise is super important. Try to get at least 2,500 steps a day, at least 4 METs, meaning, you should be able to easily handle 2 flights of stairs without any problems. But you should try to get 150 minutes of moderate intensity or 75 minutes of vigorous activity, including some resistance and weights, and then sleep at least, sleep 6 to 7 hours. Okay. And if there's some concerns for sleep apnea, talk to your doctor. Okay. Any questions?
What was that thing you said to get checked?
Lipoprotein a, LP in brackets A.
LPA test?
Yep.
Blood test?
Yep. Thank you.
Thank you.
Question.
Yeah.
In terms of exercise, what is your own personal routine, and do you prefer to work out in the morning or afternoon, or like?
Great
'Cause
question.
it's so hard to create a really nice routine, and
It is really, really
just curious
tough.
what you do.
Yeah, it is really, really tough. So I am not a morning person. I always aspire to do that. But in reality, most of the time I tend to work out more in the evenings. I usually try to encompass a mix of things. So I'm blessed to have an exercise bike at home. So I'll do that. We have a few free weights and stuff. So I'll do that. And then, yoga and stuff like that. I always mention YouTube is a really good resource. There's a ton of free exercises there. There's like all these different channels where they have all kinds of in levels of intensity, from things like, you could even type in, for some people, yoga for seniors or something like that, to, like hardcore, what's it called? What's the word I'm looking for?
Hot yoga?
No, I'm thinking of like the CrossFit. Yeah, so you can go like from like super intense, these like, gym rats that are like in there, like, way putting me to shame. I think that the key, and I'm speaking to myself before I speak to you guys here when I say this, we just have to make it a priority. I heard another cardiologist say this, which I really felt like it spoke to me, is most of the time when we don't exercise, it's because we say we're too tired, right? We would never say we're too tired to pick up our kids when they're somewhere. And it's because nobody's saying don't make your kids a priority, but like the point is that we make them a priority and we don't prioritize our health. And that's really, really the issue. So, but yeah, that's kind of a mix of some, hit exercises, bike, and then weights. In the summer, I never used to be a runner, but I started running the last like year or so, just in trail nearby. So, anything else?
One more question.
Yeah.
Sorry, you go ahead. You go first.
What is excuse me, about yoga over other exercises, the mental?
I think it's a mix of.
lowering stress that lowers the
I think it's a
cholesterol?
mix of multiple things. So number one, if you look at how yoga is done, first of all, it's basically putting yourself into a difficult position without really, like say, you're bending in a way. So a lot of focus, for example, on this one muscle, and it's putting all your mental energy into that without really, you know, working hard and grunting and that sort of thing. So you have that mental aspect where I'm kind of focusing all my attention here, a lot of the deep breathing and that sort of thing. And then again, the balance and the flexibility and that sort of thing. So I think it's a kind of just that perfect storm to have a mix of all of that. I at the same time would not say that somebody's doing purely yoga, that's good enough. Like, I think that you need to have some of that cardio and to have certainly some of the resistance work and that sort of thing. But that's why I think that it's beneficial. I don't know if anybody ever had heard of, there's an exercise program a few years back called P90X. But P90X, like, you know, again, was really mainly focused on building muscle and you know, ability to like run faster, jump higher, that sort of thing. But they incorporated yoga in it. And so it was around that time that I personally started doing yoga. I had done that program, and I really felt like it helped me a lot. And so, but then since then, you know, I've seen all the data that shows all the benefits and things. So that's why I include that. So, again, YouTube, great resource for yoga. Yeah. Go ahead.
What's your thoughts on cayenne pepper? I hear a lot of things about it. It's very good to thin the blood, and in third world countries, they can even use it sometimes to help somebody who's having a heart attack or something on the spot.
I don't know if I would jump that far, but certainly there's no question that actually peppers and hot, you know, spicy foods, we definitely see improvements in terms of cardiovascular disease. And so, yeah, you know, just to, you know, just maybe think of this, that one thing I would say to be a little bit careful about is there's definitely claims that certain people will make of different vitamins or you know, different foods or things like that to incorporate. And the way that it's presented, a lot of times it's almost like a cure-all or like a definitive thing. And I think, you know, which I was kind of getting at when I had the slide in terms of the diet, some of these things are a little bit hard to really pin down. And some of them maybe work in theory, but in practice, in terms of the ultimate endpoint, which we really care about, which is how well does it do to actually prevent an event, it might not go that whole way. Okay, so I'll give you another example. Cinnamon, for example, definitely can help with sugars, with you know, and we're talking about like actual ground cinnamon, not like, you know, Cinnamon Toast Crunch. But that can definitely help, for example, improve someone's A1C, which is one of the markers we use for diabetes. It's not a huge amount. And so sometimes you'll see people just tout that, like, oh, you just have this and you'll be good. You know, I'd seen a video earlier today, somebody had sent me, where it's like a mixture of lemon juice and I forgot what else is in there. Like, oh, drink this every single day and, you know, you'll be fine. And, you know, these things maybe can help a little bit, but, you know, I think that we just need a little bit better data in certain cases. And in other cases, they've proven that it actually is maybe not enough. So the only reason I mention this is, you know, I wouldn't tell you not to do that. Cayenne pepper for sure. And generally, like I said, peppers have a lot of benefit, but I think that we have to be have a little healthy skepticism whenever we approach these things. All right. Anything else? No?
Thank you.
Thank you so
Thank you.
much. I appreciate you all coming out. Great questions.
Did you bring your business cards?
I have a few, actually. It just happened to keep with me, but
You're interested.